In the present question, there is a graph given and they are asking us which of the following peak is responsible for causing the ovulation. And what you find in the graph is on the x-axis, the days of menstrual cycle are given, generally taken as 28-day cycle, where the mid-cycle day number 14 will have the ovulation. Along with that, on the y-axis are shown the concentration of the hormones. Basically, 4 hormones we talk about: the FSH, LH, estrogen, and progesterone. So, which among the 4 will be achieving a peak and leading to the ovulation, rupture of the Graafian follicle, and release of the secondary oocyte? Before we mark the answer, let us gather some details first. This present diagram is talking about the brain, the hypothalamus pituitary axis. This hypothalamus pituitary gonadal axis we need to discuss. This is the gonad, the ovaries here. Also shown is the uterus with the uterine tube. We also need to discuss about the uterine endometrium, which will be getting ready for implantation if there is fertilization taking place. Now, before we start talking about the uterine endometrium, let us focus upon the ovaries. The cycle is divided into 2 parts: pre-ovulatory, which is follicular phase for the ovaries, and post-ovulatory, which is luteal phase. And now let us look at the hypothalamus region. From the hypothalamus, we'll see there are gonadotropic releasing hormones being released, and they are working on the anterior pituitary. The anterior pituitary itself will be releasing the hormones which are the follicle stimulating hormone, the FSH, and luteinizing hormone. This all happens right from the beginning of the menstrual cycle, day number 1. So here you will find as the levels of FSH and estrogen are increasing, we find they are now stimulating the developing follicle. These follicles are inside the ovaries each menstrual cycle. One of the ovary will develop the Graafian follicle for the release of the secondary oocyte during ovulation. Now, as multiple follicles are being stimulated by this FSH and the LH, we see the follicle which has the oocyte and the granulosa cell, the theca cells, they are secreting estrogen, and the levels of estrogen is increasing. We have to remember that the first half of the cycle, pre-ovulatory cycle, the levels of estrogen keep increasing. This is the follicular phase. And if you're talking about the progesterone, which are also secreted by the theca cells, the level of progesterone will be actually taking a peak but post-ovulatory cycle, after ovulation. Now, before you talk about the progesterone peak, let us come back to the estrogen peak. As the hormone estrogen is taking a peak, it will stimulate the luteinizing hormone surge, and it is the luteinizing hormone surge which will then attain a peak. Because of that, there will be release of secondary oocyte by the rupture of the follicle, what is called as the ovulation. So you see, the secondary oocyte is now being ovulated, and it happens because of LH surge. You can notice one more thing: the time when LH surge is occurring and reaching a peak here, LH peak, the same time there is even the FSH hormone, follicle stimulating hormone, attaining a peak. But the concentration of FSH as compared with LH, you will see there's a huge difference. The peak of LH is quite higher as compared with FSH peak. Both of them occur before ovulation. So before ovulation, there are 3 peaks. First, we have the estrogen taking a peak, which will then stimulate the LH peak. Simultaneously, there will also be FSH peak. But if you are asking about the ovulation, the first answer should always be it is the LH peak which leads to ovulation, and the secondary oocyte is released. Now, if there was a copulation occurring before ovulation and the sperms, they have entered through the vagina, cervix, uterus, and uterine tube, and reaching the ampulla of the uterine tube, they were waiting for the secondary oocyte. But usually this will not be the case. We will not have the sperms available here. So most of the time during menstrual cycle, there is no fertilization occurring. If no fertilization is occurring, no conceptus will be formed, then the structure, which is the remnant of the Graafian follicle, the corpus luteum, which was supposed to produce the hormone progesterone. Remember, progesterone, pregnancy. Progesterone is the hormone of pregnancy. If you want the pregnancy to sustain, you must have adequate level of progesterone. And that is why this corpus luteum, the thicker cells, they were producing more of progesterone, less of estrogen. And you see the levels of progesterone are more as compared with the levels of estrogen. But both of them were taking a peak as stimulated by corpus luteum. Now, if you do not have the fertilization occurring and there is no conceptus form, corpus luteum will not continue producing the hormones and the levels of progesterone is going down, and so is the estrogen level going down. The corpus luteum will change into corpus albicans and then the next cycle should begin. So as we understand, for maintaining the pregnancy, we must be having the corpus luteum persisting, and it can persist only if there was a conceptus. There will be secretion of HCG hormone, human chorionic gonadotropin, and that will keep the corpus luteum working. But in this case, we saw it was degenerating because there was no fertilization. Now let us look at the uterine endometrium also. What will be the effect of these hormones on the endometrium during the menstrual cycle? Here we have seen the follicular phase of the ovaries and luteal phase as well. What about the endometrial phases that can be seen in the next diagram now? So here, as we said, it is the uterine endometrium which is getting ready for the implantation of the conceptus if fertilization takes place. In the pre-ovulatory 14 days of the cycle, you will find there are two phases for the uterine endometrium. First few days, it will be the menstrual cycle, the menses taking place, and you will notice that uterine endometrium was being eroded due to lack of the progesterone. But then, as the hypothalamus on day 1 itself started secreting gonadotropin releasing hormone, and there was release of FSH, LH. This FSH and LH, not only they were working upon the follicles, these follicles, as they produce the estrogen, that estrogen is responsible for the proliferative phase of the endometrium. So, as we notice, the pre-ovulatory cycle where the estrogen is stimulating the endometrium, there will be endometrial proliferation. Even the arteries, they become spiral. The glands, they are growing and getting ready for the next stage, which is post-ovulatory or secretory phase. It is called secretory because you'll find that the glands also, they have proliferated and a lot of secretions are coming. The arteries have become quite spiral and producing a lot of vascularity here. This is the uterine endometrium which is ready for implantation, and that is to be maintained by the next hormone, which is progesterone. Understand, uterine endometrium, the proliferative phase is controlled by estrogen, whereas post-ovulation, when the endometrium is ready for implantation, that stage is maintained by progesterone. So we need continuous supply of progesterone, which is taking a peak in the second half of the menstrual cycle, and that progesterone was being produced by the corpus luteum. Now, since there is no implantation, since there is no fertilization, no conception, no implantation, corpus luteum will not sustain and will change into corpus albicans, and that is why the level of progesterone will come down. And if the level of progesterone comes down, then the endometrium cannot sustain, and that is why as the cycle is completed, the endometrium will be sloughing off, and beginning of the next cycle, menses will take place. Loss of progesterone support, the blood vessels will break, endometrium except the basal layer will break and be sloughed off, coming out as menstrual flow. And what if there was sperm available? If sperm was available, then secondary oocyte will be fertilized, there will be conception, and the conceptus will come back to the uterus, there will be implantation, and when there is implantation, the embryonic tissue will secrete HCG, human chorionic gonadotropin, which will sustain the corpus luteum. It will become corpus luteum of pregnancy. P for P, it will produce more of progesterone, and the endometrial growth will be sustained. The baby will start growing hair, will be getting implanted, and pregnancy continues. Anyhow, what about our question? Let us go back to our question now. The question was asking us which of the following hormonal concentration, the peak, is responsible for ovulation. And by now we understand two of the hormones will be peaking just before ovulation. One hormone will be peaking before ovulation and even after ovulation, but one hormone is peaking only after ovulation. So the one which is working in the post-ovulatory cycle, this marker D, is the progesterone. Then What about the hormone which takes a double peak just before ovulation and even post-ovulation? It was corpus luteum, which was producing more of progesterone but also estrogen. So this graph is for estrogen or the marker C. In fact, it is the estrogen taking a peak before ovulation, and that leads to LH surge also. And increasing level of estrogen leads to increasing level of LH hormone. This is where we are having the LH surge, and then there will be LH peak also. So marker A is the luteinizing hormone, and because of the LH peak, day number 14, there will be the mid-cycle and ovulation taking place. Obviously, before ovulation, you have a peak of another hormone, which is FSH, follicle stimulating hormone. But as we have noticed, the level of FSH as compared with the level of LH peak, which one is having a higher concentration? And that was LH hormone. Both of them are peaking before ovulation. Both of them will be leading to ovulation. But if a choice comes, it is the LH surge which should be answered, or the marker A should be answered. Now, when you say your answer is choice number A or marker A, which is LH surge, also remember LH surge will be taking place approximately 36 hours before ovulation. And what about the LH peak? LH peak will occur approximately 12 hours before ovulation, and that is the time 12 hours before ovulation the first polar body is released. And remember, now we have got only 24 hours post ovulation for fertilization. Means the secondary oocyte which was ovulated mid-cycle must be fertilized by day number 15 within 24 hours. Otherwise, secondary oocyte is degenerated and menstruated. So in this particular question, it is the LH peak which is responsible for the ovulation, and it is the marker A as our answer. This question is asking us about the type of collagen fibers present in the joint capsule. So obviously they are talking about some synovial joint lined by the capsule, and the collagen types can be several, out of which 4 are given here. Let us make a table and discuss where do we find these 4 type of collagen fibers, and then we can come back to answer our question about the joint capsule. So here we make a table and discuss the type 1, 2, 3 and 4 collagen types and their respective sites. So we understand that type 1 is the most common type of collagen in our body, and one good example is the bone tissue. So bone will have type 1 collagen. What about cartilage? When we talk about the cartilage, it is type 2. But remember, it is which cartilage you are talking about? Hyaline and elastic cartilage. Now, when you say it is the hyaline and the elastic cartilage which is having the type 2 collagen, what about the third type, the fibrocartilage? Fibrocartilage is a typical cartilage and will have predominantly type 1 collagen. So we can keep it here by telling fibrocartilage is a typical cartilage as it has more of type 1 collagen just like bone and less of type 2 collagen. Fibrocartilage, which is atypical cartilage, behaves like bone not only in having type 1 collagen predominantly, but it can also be vascularized. It can have neural bundles as well. Generally speaking, neurovascular bundle should be absent from cartilages like hyaline cartilage, elastic cartilage. They are non-vascular, non-nervous. If you cut them, there'll be no bleeding and there'll be no pain as well. But when it comes to fibrocartilage, especially during repair, it is getting vascularized, it is getting neural tissue as well. So it is a typical cartilage. Now here I'll put one more detail. Most of the organ capsules, they will have type 1 collagen. And when I'm talking about the capsules, there we have to put one more thing. Not only the organ capsules, capsule means something which covers the organ, even the covering of the bone, which is called as periosteum. So capsule of the bone or covering of the bone, the periosteum, is also having type 1 collagen. Now, be careful when I keep adding more information. This type 1 collagen is also found in the capsule of the cartilage. What is a capsule of cartilage called? It is called perichondrium. And as I'm suggesting, be careful when it comes to perichondrium. The covering of the cartilage, it is also type 1 collagen. Or I'll tell you this way. If somebody is asking hyaline cartilage and elastic cartilage, which collagen? It is type 2. But what about their perichondrium? If we are talking about their perichondrium or their capsule, then it is type 1 collagen. So may it be periosteum or may it be perichondrium, it is capsule covering the structures and it is type 1 collagen. You remember our question was on joint capsule. So joint capsule, which collagen? It will be type 1 collagen. Then where do you see type 3 collagen? Type 3 collagen can be at certain places. Like one example is lymphoid organs. The lymphoid organs, like you have the liver or the spleen or the lymph node, they have type 3 collagen, which is also called as reticular fibers. These are reticular tissues. So type 3 collagen, the reticular fibers are present in lymphoid organs like liver, spleen, lymph node. And what about type 4 collagen? When it comes to type 4 collagen, you can answer basement membrane. So in the basement membrane, which is a filtration barrier, you have the type 4 collagen. Now, there are still more questions coming up on that type of collagen and their locations. But at the moment, let us just focus upon the details related to our question. So here, let us talk about one synovial joint, maybe the knee joint, where the upper bone femur is articulating with the lower bone tibia. Since it is a synovial joint, it will have a synovial cavity covered by a capsule. So here, the upper bone, let us take it as the femur from above and the lower bone, the tibia from below. Now, as we are looking at this synovial joint, the knee joint will have a capsule. This is the capsule connecting the two bones. Now, this capsule, which is connecting the two bones to create a cavity, the synovial cavity, you have to understand that it is made up of collagen fibers. And which collagen fibers? You remember organ capsule or the capsule of the synovial joint or the capsule of the bone, the periosteum. So may it be the periosteum or the capsule, they'll have type 1 collagen. Now, when you say they are having the type 1 collagen, it is understood that it is the periosteum covering the bone becomes continuous with the capsule so that you do not have periosteum inside the capsule. Actually, inside the capsule, inside the synovial joint, you do not have periosteum or perichondrium like this cartilage, which is articular cartilage. Generally, it is hyaline cartilage. So this articular cartilage or the hyaline cartilage will have no perichondrium here. No periosteum, no perichondrium. What about this cartilage, which is working like a articular disc? Now, this articular disc, if you were talking about the knee joint, could be the meniscus. So knee meniscus or any other joint having an articular disc, which cartilage is that? That is fibrocartilage, the atypical cartilage. Now, understand that the capsule on the inner side is lined by synovial membrane, and that synovial membrane is going to line the capsule from the inside, but then it does not line the articular surface. So, synovial membrane, which is lining the inner side of the capsule, will be lining the bone, but only to that level where you have non-articular surface. When it comes to articular surface, it is not lined by synovial membrane. It is actually lined by the articular cartilage. So, again, we can show this is the synovial membrane on the non-articular bony surface. Then it is also lining the inner surface of capsule. And once again here. So, what was our question about? Our question was asking, in a synovial joint, the capsule, which type of collagen is there? And we said, may it be periosteum on the bone or the capsule, they'll have type 1 collagen. And where else will you have type 1 collagen? Type 1 collagen will also be found in atypical cartilage, which is fibrocartilage. So fibrocartilage, atypical cartilage, the one which you are showing here, is also having the type 1 collagen. So that means everywhere we have type 1 collagen? Yes, of course, but not in the articular cartilage. Most of the articular cartilages are hyaline cartilages. So the articular cartilage will be actually type 2 collagen. So here you can mention the articular cartilage, which is hyaline cartilage, will have type 2 collagen. But what about its perichondrium? I told you inside the capsule there is no periosteum or no perichondrium. So no discussion of perichondrium at all. The articular cartilage, mostly which is hyaline cartilage, is without perichondrium inside the capsule and is type 2 collagen. Why we are specifically talking about various components and collagen? Because next time the same question will not come. They'll change the choices and you should be ready with the answer. Now one question has come. It is asking which cartilage do not calcify. Especially they are asking for larynx cartilages. So remember one thing, the hyaline cartilage have a very high tendency to calcify and ossify. Even the fibrocartilage can be calcified and ossified, but not the elastic cartilage. Like in the ear pinna, you have elastic cartilage. It does not calcify, it does not ossify. Let me write it down in a separate diagram. But before that, you answer the previous question. The type of collagen which is found in the capsule. May it be the organ capsule or the joint capsule or the capsule of bone which is called as the periosteum or the capsule of the cartilage which is called as the perichondrium. All of them will have which collagen? That is the type 1 collagen. Choice number A is the answer. And then let us talk about the three type of cartilages and their calcification. This is the question we have got. It is asking which of the following cartilage is not undergoing calcification with age and giving you some examples of the larynx cartilage. Let me first tell you almost entire body except the few skull bones, clavicle bone is developing in hyaline cartilage. Endochondral ossification. The fetal cartilage, if you look at that, you will notice it is all made up of hyaline cartilage. So fetal cartilage, which is the bony model, in the beginning, most of the bones in our body, you can talk about the upper limb bones, the lower limb bones, the ribs, the vertebra, they are all actually hyaline cartilage. Then what happens is, after some time, there occurs endochondral ossification and this hyaline cartilage undergoes calcification and ossification. Now, when it is undergoing calcification, ossification, you will notice that most of the hyaline cartilage has changed into bone, but there is some portion which is still hyaline cartilage. So, which portion is still hyaline cartilage? It is the persisting cartilage at the ends. So, entire structure has changed into the bony tissue except for the ends, and these ends are still the hyaline cartilage, and that is what you call it as the articular cartilage. So, when we are talking about the articular cartilage, it is at the ends of the long bones and it is still hyaline cartilage, as we could see in the beginning. So this was fetal cartilage and it was all hyaline cartilage. Now tell me, which collagen will you find in the adult bone? And as you know, if you are talking about the hyaline cartilage, it was type 2 collagen. So type 2 collagen will be remaining in the ends of the adult bone, whereas if you are talking about the rest of the bone, it will have type 1 collagen. So bone will have type 1 collagen. This we have discussed earlier as well. But here we want to talk about calcification. So remember, hyaline cartilage has a very high tendency to calcify and ossify, except the articular cartilage. Articular cartilage do not calcify calcify, do not ossify. This comes as an exception as a question as well. Then which other cartilage do not calcify, ossify? The elastic cartilage, like you see pinna in the ear, elastic cartilage do not calcify, ossify. Then what about the fibrocartilage? If you're talking about fibrocartilage, it has slight tendency to get calcified and ossified. So you can write here three type of cartilage: hyaline, the elastic cartilage, and the fibrocartilage. You notice hyaline cartilage very high tendency to get calcified, ossified, except for articular cartilage, and fibrocartilage has good tendency to get calcified, ossified, but the elastic cartilage never calcifies or ossifies. Now that will give an idea to the answer of this question. It is asking which of the following cartilage do not calcify. Larynx cartilages. Let us look at the larynx cartilages first, which are mostly hyaline cartilages, except few which are elastic cartilages. So can you name the larynx cartilages? There are total 9 cartilages in the larynx. Then we can come back to our question. This is larynx cartilage looking from the anterior view and then posterior view. Let us draw a diagram ourselves as well. Larynx cartilages in the anterior view and the posterior view. So you will understand that from the anterior view, the largest cartilage of larynx can be seen, which is the thyroid cartilage. You draw it here, the thyroid cartilage. Now, along with the thyroid cartilage, you can see one below that, which is a ring-shaped cartilage, circular fashion, and seen anteriorly as well as posteriorly. So show it anteriorly, the cricoid cartilage. Now, this is the cricoid cartilage, which is actually a ring-shaped cartilage. So not only seen anterior, but also seen posterior. Though posteriorly, it will be seen larger. As you can see here, anteriorly it is narrow, posteriorly it is large. The cricoid cartilage, ring-shaped cartilage, covering the respiratory tube at the level of the larynx. And what is sitting on the cricoid cartilage? This is a pair of arytenoid cartilage. So a pair of arytenoid cartilage. What is over that arytenoid cartilage in the posterior view of larynx? The corniculate. And as you show the corniculate cartilage, over that you'll have a pair of cuneiform cartilage as well. So over that you have the cuneiform. Now this is the cuneiform pair, that is the corniculate pair. This is the pair of arytenoid, but the cricoid is a single cartilage, a midline cartilage like thyroid. There is one more midline cartilage which is only one, and that is the lid over larynx, epiglottis. You can see here, this is only one in the midline, and it is epiglottis. Epiglottis can be seen from the front view as well. So you can show epiglottis here from the front view as well. Though it is shown here posteriorly, but can be seen anteriorly as well, like a lid over the larynx. Now the thing is, most of the larynx cartilages are hyaline cartilage except few. So which few are not hyaline? And if they're not hyaline, then what are they? Let me shade the area now. The tip of the arytenoid cartilage is actually elastic cartilage, and so is the corniculate and the cuneiform, and also the epiglottis. Means what are they? They are elastic cartilages. Who all is elastic cartilage? Tip of the arytenoid and the corniculate, cuneiform, and the epiglottis. They are elastic cartilage. They do not calcify. Then which one is undergoing calcification? The thyroid cartilage and the cricoid cartilage and most of the arytenoid cartilage. Now understand that these thyroid, cricoid, and most of the arytenoid, which are hyaline cartilage, which are prone to undergo calcification and ossification, that will happen after adolescence, means after the age of 18 to 20 years. There was an elderly male, 58 years old, a car accident, and there is injury to the larynx, fracture of the larynx. Now you'll wonder, how come there is a fracture? Because his thyroid cartilage, cricoid cartilage is born by that age. The thyroid and cricoid, they are hyaline cartilage. They have a tendency to calcify, ossify in the adult age, especially at the age of 60, 70 years, they have become almost bone. So fracture of the bone. So what is the problem? Problem is cricoid cartilage is a ring-shaped cartilage. It is around the respiratory tube and it can compress the respiratory tube, difficulty breathing. Patient can have emergency. So what you do is you put a tube into trachea, tracheostomy, and then you have to repair the cricoid cartilage. So that is the importance of knowing larynx cartilage can undergo ossification after calcification. And which one do not ossify or calcify? They are already given. Tip of the arytenoid, cornicate, cuneiform, and epiglottis are elastic cartilage. They do not calcify or ossify. That was the question. Let's go back to the question. It was asking which of the following cartilage do not calcify, ossify with age. Most of the larynx cartilage are hyaline cartilage. They do calcify and ossify with age, except few of them, and one of them is the epiglottis. Choice number D is the answer. We have learned epiglottis and tip of the arytenoid, and then it is the cornicate and cuneiform. They are elastic cartilage, do not undergo calcification. But sir, arytenoid is written here. Yes, most of the arytenoid is hyaline cartilage. Only the tip is elastic. So there can be a confusion here that will the arytenoid undergo calcification? Of course, except the tip. Tip is elastic, it does not calcify. Along with someone sitting on the top of that cornicate and cuneiform do not calcify. Keep your answer as choice number D here. This question is asking us about the corticospinal tract, which is coming from the cerebral cortex towards the spinal cord, as the name is suggesting. Where is it crossing the midline? It is also called as the pyramidal decussation because it is a component of pyramidal tract. Now, before we mark the answer here, we understand these are the components of the brain stem. Brain stem having the midbrain, pons, and the medulla oblongata. So let us look at a diagram and then we can come back to our question. Find the answer. Now here we are looking from the front view so that we can see the highest brain, the cerebral cortex, and then also the brain stem having the midbrain, pons, and the medulla oblongata continuing further downward as the spinal cord. Now we have got the upper motor neurons at the level of cerebral cortex here. As you can see, these are the upper motor neurons. Body is represented upside down, the homunculus. If you want to control the lower body, the upper motor neurons are located here. If you want to control the upper body, then the face motor neurons are present here. These upper motor neurons are going to control the lower motor neurons, and lower motor neurons then control the skeletal muscles. You have got lower motor neurons either at the level of brainstem as shown here, or at the level of spinal cord down there. From the spinal cord, when the upper motor neurons are synapsing on the lower motor neuron, the spinal nerves will be carrying the information to skeletal muscles so that skeletal muscles can contract. And in the brainstem, it will be the cranial nerves which are controlling the skeletal muscles, their contraction. The upper motor neurons have modulatory effect upon lower motor neurons. That means upper motor neurons can inhibit or excite the lower motor neurons depending upon the level of activity you want. But usually they are inhibitory in controlling the lower motor neuron, especially if you are talking about this pathway, the corticospinal pathway. Anyhow, it is also to be understood the upper motor neurons on one side of the body control skeletal muscles, on the other side of the body contralaterally. So where is the crossing occurring? And that is what is the question asking. If it is the face area, the cranial nerves, you will find the pathway is called as corticonuclear tract, and it is crossing at the same level where you have got the lower motor neurons located. If the cranial nerve nucleus is in the midbrain, it will cross at the level of midbrain. Or if it is in the pons medulla, the crossing of corticonuclear fibers in the midline will be at the same level. But that doesn't happen with the corticospinal tract. So where the corticospinal tract fibers are crossing, if not at the same level of synapse with the lower motor neuron. You will notice now, as the corticospinal tract is starting from the cerebral cortex, it has to pass through the internal capsule, and passing the internal capsule keep running on the same side of the midline till the lower level of medulla oblongata in the brainstem. It is at the level of lower medulla. You will find what is called as the pyramidal decussation. Since it is a motor pathway, the motor decussation, and then it will start running on the other side of the spinal cord and come down to the lower motor neuron and synapse there. So the thing is, clinically, if you have got a case of Brown-Séquard syndrome on the right side of the spinal cord, then it is a UMN type of lesion and the right side of the body will be affected. It will be right-sided spastic paralysis. Now, why spastic paralysis? Because it is a UMN type of lesion. As I mentioned, upper motor neurons are usually inhibitory to the lower motor neurons. If you remove the inhibition, if there's a lesion, lower motor neurons become free to fire. Frequently, they keep firing, and the muscles, the skeletal muscle will go into spasm, spastic paralysis. So, right-sided Brown-Séquard syndrome, you will have spastic paralysis below the level of lesion. The lower body will have spastic paralysis on the same side of the lesion. Then, what about a lesion which is in the brainstem? If there is a lesion in the brainstem, this lesion to the corticospinal tract will lead to UMN type of palsy, but on the opposite side of the body. So, if there is injury of corticospinal tract on the left side of midline, then you will find the patient will have contralateral spastic paralysis problem on the right side of the body. And what if I have a lesion in the posterior limb of internal capsule? If there's a lesion in the posterior limb of internal capsule where the corticospinal tract is passing, again there will be contralateral spastic paralysis. Lesion is on the left side of internal capsule, the posterior limb, and problem will be on the right side of the body. So that means lesion 1 was having ipsilateral problem, lesion 2 and lesion 3 will be giving us contralateral problems. Because if the lesion is before the crossing, the problem will be contralateral. And if the lesion is after the crossing, then problem is ipsilateral. The problem is on the same side of the lesion. So where is this crossing happening is important clinically. Lower medulla. Now let us look at diagrams about sensory decussation, crossing of sensory fibers. Now what you find here is again the front view of the body, and shown is the spinal cord. After that it is the brainstem region, then it is the thalamus region, which is the relay center towards the highest brain, that is the cerebral cortex, where you have somatosensory cortex broadband number 1, 2, 3. So to reach this broadband number 1, 2, 3, the information is passing through the relay center, that is the ventro-posterolateral nucleus of the thalamus. Before that it will be passing in the brainstem, but it has actually started at the level of spinal cord. This is the dorsal column medial lemniscal system. This system is carrying some sensations, like you will find deep pressure, deep touch, vibration, stereognosis, conscious proprioception. It is conscious because reaching the conscious level, the cerebral cortex. So these 5 sensations which are carried by dorsal column medial lemniscal system. The first order neuron to receive is the dorsal root ganglion, and it depends whether the information is coming from the lower limb or the upper limb. If it is body below diaphragm, you will have the dorsal column running as the fasciculus gracilis, and if it is above the diaphragm, like upper limb sensation, then the information running by fasciculus cuneatus. This fasciculus cuneatus and fasciculus gracilis together, they make the dorsal column, and this dorsal column is the first order neuron running on the same side of the spinal cord. Then this fasciculus gracilis and fasciculus cuneatus, they have to synapse in the second order neuron, which is nucleus cuneatus and gracilis. This nucleus cuneatus and gracilis, they are present at the level of the middle medulla oblongata, and at the same level sensory decussation. You see the fibers are now crossing. These are second order neurons and they are crossing, and this happens in the middle medulla oblongata. The point is, sensory decussation occurs in the middle medulla. Where was the motor decussation happening? Previously we have seen lower medulla. So lower medulla, motor decussation, and middle medulla, it is the sensory decussation. Now the second order neuron is going to constitute the medial lemniscal system, which is running on the other side of the midline. Means the five sensations which were carried from one side of the body, say right side, will be carried towards the medulla oblongata on the right side in the spinal cord, first order neuron, but then the medial lemniscal system runs on the other side, on the left side. And where is it reaching? The third order neuron in the thalamus. And the third order neuron in the thalamus, the ventroposterolateral nucleus of the thalamus, third order neuron will be passing through the posterior limb of ventral capsule to reach the cerebral cortex, area number 1, 2, 3. What will happen if I have a lesion in the posterior limb of ventral capsule on the left side? Now, if you got a lesion on the left side posterior limb of ventral capsule, the five sensation will be lost on the other side of the body. The lesion in the ventral capsule is on the left side. The problems will come on the right side. Right side of the body will lose the sensation of deep pressure, deep touch, vibration, conscious proprioception, and stereognosis. This is patient number 1. Patient number 2, there is again a lesion on the left side, brain stem. So left-sided lesion in the brain stem. Again, the problem will come on the right side of the body. Patient number 2. Now, patient number 3. We have got a case of Brown-Séquard syndrome, which is lesion of the spinal cord, hemisection of the spinal cord, but on the right side. Patient number 3, the problems will also be appearing on the right side, means right-sided problem of the five sensation. See, the point is, if the lesion occurs after sensory decussation, then maybe patient 1 or 2, the problems will be coming contralaterally. But if the lesion is before sensory decussation, then the problem will be ipsilateral on the same side. That is the importance of knowing where the sensory decussation is happening. If the lesion is before that, problem will be same-sided. And if the lesion is after that, problem will be on the opposite side of the body. And then you can understand if the question is asking us about corticospinal tract, the pyramidal tract coming from the cortex towards the spinal cord. Where was the crossing? That is the question. Crossing the midline at the level of medulla. But which medulla? It was the lower medulla. And what was happening in the middle medulla? It was sensory decussation. Sensory decussation, which tract was that? That was the dorsal column medial lemniscal system. And which sensation it was carrying? Five sensations. The sensation of deep touch, deep pressure, vibration, stereognosis, conscious proprioception. But anyhow, since this is a question on the motor tract, motor decussation, the answer should remain lower medulla, the pyramidal decussation. Choice number D is the answer. Here we have got a question which is a dissected specimen of the oral cavity. Some arrow mark is shown. They're asking, what is this muscle with the arrow mark? For orientation, let us magnify this diagram and show it along with the diagram of the face. Then we can come back to mark our answer. So basically, it is showing a muscle of the tongue. One section has been taken. It is a mid-sagittal section, anterior to posterior in the midline. And in the mandible, you will find there is a superior genial tubercle. From the superior genial tubercle on the inner side of the mandible, one tongue muscle is taking origin, and it is the largest muscle of the tongue. It inserts into the tongue and partly into a bone here, which is called as the hyoid bone, the bone of the neck region. So, which muscle are we talking about? You'll notice here the origin is superior genial tubercle of the bone, mandible, hair. For orientation, this is the lower lip, the upper lip, this is the palate region, and the oral cavity showing the tongue. This is the dorsum of the tongue. So one muscle of the tongue, the largest muscle of the tongue, genioglossus, is being marked here. This muscle taking origin from superior genial tubercle, inserting into almost the entire tongue and also into this bone, which is called as the hyoid bone here. So the name of this muscle is genioglossus, the safety muscle of the tongue. Why is it called the safety muscle of tongue? Because it is preventing the backward falling of the tongue into the respiratory tube. Actually, this is the muscle which takes the tongue anterior. It protrudes the tongue outside the oral cavity. Now, the tongue is having extrinsic muscles and intrinsic muscles also. You can notice one of the intrinsic muscle here, and that is the longitudinal muscle, superior longitudinal muscle, running longitudinally anterior to posterior, and there is a superior longitudinal muscle. There is one inferior longitudinal muscle also, which will become more evident in another diagram when we look from the front view. But at the moment, let us continue with the same diagram. Since this diagram has been taken in the midline, you cannot see the other extrinsic muscles of the tongue. So in the next diagram, you can see the 4 extrinsic muscles of the tongue, out of which one we already have seen, genioglossus. Now here, once again, you're looking from the side view. The previous diagram was actually a midline, mid-sagittal section. This is looking slightly from the lateral view, coming to one side, and you can mark the muscle again. The genioglossus muscle here, as you show the muscle, you'll find it was spreading quite in an elaborate fashion, the largest muscle of tongue, and is evident here as well. Now, this is genioglossus. What about the other muscles? Their names are according to the bony attachment. Like here it was the upper genial tubercle of mandible, hence the name genioglossus is the tongue. Then you will notice one muscle attaching to hyoid bone and the tongue, hence the name hyoglossus. This is the hyoid bone. As you can notice, the bone in the neck region below the mandible bone, it will be found here, the hyoid bone, or you can show it here as well, the hyoid bone. But there you cannot show hyoglossus muscle because it is slightly away from the midline. So one is genioglossus, other is hyoglossus. The third one is attaching to the styloid process in the skull bone. As you will notice, it will be here behind the ear. Styloid process coming from the base of the skull, and there attaches the muscle. The name, as you can see, styloglossus. So let us mark the styloglossus muscle here. You can see it is inserting into the tongue now, the styloglossus muscle. So what is the 4th muscle? Because there are 4 extrinsic muscles. The one which attaches to the palate and the tongue, palatoglossus, and it is shown here coming from above. Above means from where? See, at the roof of the oral cavity, we have got the palate. It is coming from the palate, and hence the name palatoglossus. So it is coming from the roof of the oral cavity, the palate region, and hence the name will be palatoglossus muscle as shown here. Remember, palatoglossus is the only muscle of tongue which is developing in the pharyngeal arches, arch number 4. That is why it will have a separate nerve supply. Otherwise, tongue muscles, they develop from occipital somites and supplied by hypoglossal nerve, cranial number 12. So all the tongue muscles are supplied by 12th nerve, hypoglossal nerve, except palatoglossus, because palatoglossus do not develop from occipital somites. It is developing in pharyngeal arch number 4. It's a muscle of palate, palatoglossus, and tongue as well. So it will be supplied by vagus accessory complex, cranial number 10 and 11, cranial accessory nerve, fibers carried by vagus nerve. Vagus accessory complex supplies the palatoglossus. What is the function of muscle? As you can see, it can elevate the tongue upward. Then what is the function of styloglossus? It can retract the tongue. And who is protruding the tongue? That was genioglossus. Genioglossus can protrude the tongue, and if you want to retract it, use the styloglossus. If you want to elevate it, use the palatoglossus. And what if I want to depress the tongue? Then use hyoglossus. This is a lower bone, so it can take the tongue down. Depressor, elevator, retractor, extruder and protruder. Now, these are 4 skeletal muscles which have bony attachment. There are 4 skeletal muscles who do not have any bony attachment. Let us look at them as well. Total 8 muscles in the tongue, 4 extrinsic and 4 intrinsic. This time it is the front view of the tongue, and in the tongue there is a midline septum, and that midline septum running anterior to posterior can be shown here. And then you can mention about the 4 intrinsic muscles. As we said, the intrinsic muscles do not have bony attachment, and intrinsic muscles basically change the shape of the tongue while speaking, even while swallowing. It will help us. So what about the intrinsic muscles? As you notice, there are 4 of them. 2 of them are running anterior posteriorly, superior and inferior. Superior longitudinal muscle, inferior longitudinal muscle. As you see, since it is a coronal section, side to side, you can find this is the superior longitudinal muscle on left and right side, and similarly you can show the inferior longitudinal muscle on the left side from the front view and right side from the front view. Now, when you say there are superior and inferior longitudinal muscle running anterior to posterior direction, what about the other muscles? There is one which is vertical as well. One on the left side and one on the right side. Okay, then one more. It is the transverse muscle. So here it is the left-sided transverse muscle, and this is the right-sided transverse muscle. Seen from the front view in a coronal section of the tongue running transversely. As you can see, one on this side, one on the other side. So anterior posterior longitudinal, right to left the transverse, superior to inferior the vertical. Total 4 extrinsic muscles. 2 longitudinal, 1 vertical, 1 transverse, and 4 extrinsic also. Which extrinsic is not mentioned here? What we see here is styloglossus, genioglossus, hyoglossus, but not the palatoglossus. Palatoglossus is the muscle which do not develop in the occipital somites. All these muscles develop from occipital somites except palatoglossus, and hence all of them are supplied by 12th nerve, hypoglossal nerve, except palatoglossus, because palatoglossus is a muscle of palate developing in 4th pharyngeal arch. Vagus accessory complex is the nerve supply. And as we reach back our answer, the arrow marked muscle is the largest of all, and the name is genioglossus. Choice number C is our answer. In this diagram, we could also see longitudinal muscle. I have already marked it. Superior longitudinal muscle is evident here. Some skeletal muscle fibers. But we keep our answer as choice number C here. Here we have got a question on epidural puncture. Maybe you are giving epidural anesthesia or epidural analgesia. Which structure your needle is going to puncture before you inject the drug? Now, there are some of the components which we have to focus upon, and then we can find what could be the appropriate answer. Let us first have the orientation of the vertebra, especially the lumbar vertebra. You have put the patient in supine posture and you are looking from posterior to anterior. Posteriorly, you'll have the spine of the vertebra. Now, if that is the spine of the vertebra, what is this color? The lamina forming the posterior vertebral arch. So this is the lamina. And what is this? This is seen from the superior view. So superior articular facet, so that it can articulate with the upper vertebra. Okay, and what is this structure here? That is the pedicle. We have to focus upon pedicle as well. And what about this structure? Transverse process here on either side. And then anteriorly is the body of the vertebra. Then you will notice there is a vertebral canal through which the spinal cord is passing, or its nerve roots are passing. The spinal cord is to be covered by the dura mater, and inside the dura mater will have the arachnoid mater, and the spinal cord itself is adherently covered by pia mater. So pia mater will be the deepermost structure which is adherently covering the spinal cord. Actually, spinal cord is protected by the vertebral canal here. So where is your needle going? My needle has to come from here and reach here. Means I have to go in the vertebral canal but outside the dura mater, and that is a space which we are calling as epidural space. We want to give epidural anesthesia or epidural analgesia. I'm not supposed to puncture any of the meninges in this process. May it be dura mater, arachnoid mater. Then what are you going to puncture in the process? See, there is a ligament attaching to the spine and we call it as supraspinous ligament. There is one more ligament which is attaching to spine lying between the spines of adjacent vertebra and it is called interspinous ligament. Will be more clear when we look at another view. So spine will have supraspinous ligament, interspinous ligament which I punctured. Then which ligament am I going to puncture? The one which attaches to the lamina and that is the ligamentum flavum. So as I puncture the ligamentum flavum, then I can enter the vertebral canal or what we are calling it as the epidural space. Let us look at these three ligaments once again which you need to puncture before you reach the epidural space to give epidural anesthesia. Now, the previous view was looking at the lumbar vertebra from posterior to anterior view, as we have seen posterior to anterior view, but this time we are again looking from posterior to anterior view in a side profile, lateral view. So what will be the posterior most structure? That will be the spine of the vertebra. This is the spine of one lumbar vertebra and you can see it on the adjacent vertebra also, the spine of the lumbar vertebra. And then you can also mention the ligaments attaching to the spine of the vertebra. There will be supraspinous and interspinous ligament. So you can notice the supraspinous ligament is seen here attaching the spines. This is supraspinous ligament. And what about the interspinous ligament then? It will be slightly more anterior. So let us show it now. This is the place you have the interspinous ligament more anteriorly and it is between the spines. That is why the name is interspinous ligament. Now, what is after that? After that, we have the ligamentum flavum attaching to lamina of the vertebra. So, more anteriorly is the lamina of the vertebra, the subjacent lower vertebra, and attaching to the lamina of the vertebra is ligamentum flavum, which is attaching here on either side. So, ligamentum flavum can be shown now more anteriorly and it is between the two lamina, upper and lower lumbar vertebra. So here is the ligamentum flavum. Once you puncture the ligamentum flavum, you can enter the vertebral canal where you'll have the spinal cord covered by the meninges. As you go posterior to anterior, your needle is puncturing some of the ligaments. And that is what we wanted to know. The ligaments which we puncture to give the epidural anesthesia from posterior to anterior to reach the epidural space. So after puncturing ligamentum flavum, we'll have a popping sensation. And what is this popping sensation? This comes as a question also. See, when you are pushing the needle, your needle will have resistance because it is passing through the ligament. Sudden loss of resistance as you puncture through ligamentum flavum. Now there's empty space which is epidural space. So as you puncture ligamentum flavum, you feel sudden loss of resistance in your movement and that is called as popping sensation. Now you can inject your epidural anesthesia. How is it different from lumbar puncture, lumbar anesthesia? Let us discuss that in another diagram. So once again, it is a lateral view and we are taking a needle at the level of L3, L4 vertebra or maybe L4, L5 vertebra. You can choose any of the levels for lumbar epidural anesthesia, and when you are giving it, you are supposed to puncture some of the ligaments. So which ligament did we puncture? See, the first thing is skin and subcutaneous tissue. So first thing is the skin and subcutaneous tissue. This is the skin. Your needle has punctured here. And what is below the skin? The subcutaneous tissue. Superficial fascia, which you can show here then. Now, after puncturing the skin and superficial fascia, now you get the ligament. And what was the name of the first ligament? That was attaching the spines with each other. And called as the supraspinous ligament. So this is the supraspinous ligament. And after supraspinous ligament, we need to puncture interspinous ligament. So let us mark the interspinous ligament as well, as we are doing the epidural puncture here. This is the interspinous ligament attaching the spine of the upper and lower lying lumbar vertebra. And after that, and then the ligament attaching to lamina, ligamentum flavum. After that, we'll get the popping sensation. So next is ligamentum flavum attaching the lamina of adjacent vertebra, and we need to puncture that as well. And then we'll get the popping sensation, sudden loss of resistance, and you have entered the epidural space. Now you can give epidural anesthesia. The difference between epidural anesthesia and lumbar puncture anesthesia is the epidural anesthesia is slowly working and could be used for longer acting analgesia because the drug is distributed slowly as compared with the lumbar puncture. Lumbar puncture can be done to aspirate the CSF or give spinal anesthesia. So additionally, you have to puncture two meninges as well. And which two meninges you have to puncture to reach the CSF space, subarachnoid space? For that purpose, as you follow this needle, first you mention the details of the spinal cord. See, this is the spinal cord, which is adherently covered by the layer called as pia mater. So pia mater is also covering a structure which is called as the filum terminale. This is the filum terminale, a fibrous structure attaching to the tip of the spinal cord at the termination covered by the pia mater. Now, if pia mater is closely applied to the spinal cord, what is beyond that? That will be the arachnoid mater. Let us zoom this area a little bit and then discuss it further. As you notice, this is the spinal cord which is adherently covered by the pia mater. Beyond the pia mater, we'll have the arachnoid mater. So let us mark the arachnoid mater here. Now, what is under the arachnoid mater? Under the arachnoid mater, we'll have the subarachnoid space filled with the CSF. So that is the place we want to reach to aspirate the CSF. And that is where you can find the needle is coming for the lumbar puncture or spinal anesthesia. But before it reaches the subarachnoid space under the arachnoid mater, it would have punctured the two meninges. Number one, arachnoid mater, but before that, the dura mater as well. So let us show the dura mater. Now, see, the spinal cord itself is closely covered by pia mater. Beyond that is the arachnoid mater we have shown here. And after that, you will have the dura mater. So let us mark the dura mater. It is coming here now and on the other side as well. So the thing is, when your needle while doing lumbar puncture is passing through the skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, which sensation did you get? Popping sensation. Again, when you puncture the dura mater, there'll be resistance. And once you already have punctured the dura mater, there'll be sudden loss of resistance. This is second popping sensation. So the popping sensation are 1 and 2. The first popping sensation comes when you puncture the ligamentum flavum, and second popping sensation comes when you puncture the dura mater. And after puncturing dura mater, then you have to puncture the arachnoid mater, and then you can aspirate the CSF or you can give spinal anesthesia. It is faster in action as compared with the one which you gave here, which is epidural anesthesia. You did not puncture the dura mater. So what is the difference between lumbar puncture and epidural puncture? In the epidural puncture, you will have only one popping sensation, not the second. And this is a difficult procedure as compared with the lumbar puncture. You need more training to give one epidural anesthesia as compared with lumbar anesthesia. This is easily learnt and given. Anyhow, let us go back to our question now. The question was asking, while giving the epidural anesthesia means you are outside the dura mater. You are not puncturing any meninges. So which structure you have punctured so as to enter the epidural space and distribute the drug? The last ligament. And which was the last ligament? When you had popping sensation 1. So which ligament was that? That was actually the ligamentum flavum. After puncturing ligamentum flavum, we have entered the epidural space. You see here, this is the body of the vertebra anteriorly. Behind that comes the pedicle. And what is still behind? The lamina. And what is still behind? The spine of the vertebra. Now, once you have shown the spine of vertebra, which lumbar vertebra is this? It could be L34 or L45, doesn't matter. You can do lumbar puncture or epidural puncture at any level. So which ligament did you puncture? First is the skin, and after that we have got superficial fascia, and after that we have got supraspinous ligament. And after puncturing supraspinous ligament, interspinous ligament. And after puncturing interspinous ligament, then it is a structure attaching to the lamina, and which is ligamentum flavum. So here is the ligamentum flavum. So let us take the needle now. This is our needle, and we are doing the epidural puncture. We are not supposed to puncture any meninges. Stay outside the durameter, and this is called epidural anesthesia. While giving the epidural anesthesia, which was the structure you punctured before injecting the drug, the ligamentum flavum. Choice number B is our answer.